Hello, everybody. Welcome to today's webinar. Where the heck did I put my keys? Is it normal aging or dementia? I'm Lucy Gerland, a caregiver specialist with the Fairfax Area Agency on Aging. And we have a very special guest today who will be speaking to us. Just a few things about our webinar today. It is being recorded and it will be available to you at the end. Also, I sent out the slides earlier. If you registered after 10 a.m. or did not get the slides for any reason, just send me an email and I will send you copies of the slides. The recording will also have copies of the slides with it. So just let me know if you need anything. And all of the attendees are in listen-only mode. If you have any questions during the presentation, you have a panel probably on your right-hand side, and there's an area there for questions. Just type in your question, and I will read them at the end and get them answered. So we'll be going till about 12:45 and then take some time for questions. So our presenter today is Dr. Cynthia Sullivan. And Dr. Sullivan has been a partner at Neuropsychology Associates of Fairfax since 2006. She is also an assistant professor of neurology at the Georgetown University Medical Center and is credentialed at Inova Fairfax Hospital and Virginia Hospital Center. Dr. Sullivan received her PhD from the University of Maryland and completed her fellowship in neuropsychology at the Veterans Affairs Medical Center in Washington, D.C. Since 1998, she has also been actively involved in research. So I'm sure you're anxious to hear from Dr. Sullivan. I will turn it over to you now. Thank you.
Thank you, Lucy, and thank you to everyone who's attending today. I have a few goals for our presentation today. I want to talk first about what's normal as we get older, and then what could be some signs that things are not normal as we get older in terms of our thinking abilities, and then how do we tell the difference? What kinds of professionals do we need to consult in helping us identify that difference? And then what are some of the things that we might be concerned about if we find that it's not just normal aging? So I'm going to talk about some of the conditions that we might be thinking about, and then I'm going to talk about things that we can do to help our cognitive functioning as we get older, to try to prevent or at least reduce our risk of developing one of these conditions. So I'll start with these questions. Look over the slide. Do you ask yourself, where did I put my keys? What did I come in here for? What was I saying? And what's his name? Or what's the name of that movie we saw the other day? Or, you know, what was it that you told me last night about our plans for next weekend? You know, are you asking yourself these questions? Well, it's hard to imagine that any of you don't ask yourselves these questions at certain times. Certainly, even in adolescence, in our 20s, in our 30s, these questions are going to come up. What happens as we get older is that they come up more often, or we're having more trouble. It's taking us longer to pull up the information. So when we can't remember where we put our keys, we don't then within 5 minutes remember where we put them. We're actually having to search through the house and it's not coming to us as quickly as it used to. Same thing with coming up with a word or coming up with someone's name. So it takes us a little longer to retrieve the information. Now we might start asking ourselves, is this normal for my age or is something else going on here? The bad news about aging is that our brains do shrink as we get older. The volume of our brains is getting smaller, and this starts, unfortunately, in our mid-20s. So there's a lot of brain development as infants and through childhood and adolescence, and then at around 25, we do start to shrink a little. Now it's very, very slight and very subtle, but over the years, our brains get a little smaller. That's normal aging effect. The good news is that even though our brains are shrinking slightly, we do retain our wisdom, our intellect. We can continue to learn new information. What we find, though, is that we have more trouble coming up with names and words. that tip of the tongue phenomenon when you know what you want to say but you can't think of the word, it's just not coming to you, and you either have to stall and try to come up with it, or you just substitute in another word that's similar and hope that it gets you through the conversation. That tends to happen a little more often as we get older. Also, we tend to have more trouble multitasking, so we might be more distractible. If we get interrupted during a task, it might be more difficult for us to come back to the original task. We might forget what we had been working on, or maybe just forget where we were in the process. It's a little harder to keep multiple balls in the air. We also get a little slower in our ability to process information. So that means that when we're trying to work through something in our heads, we might be a little slower in working that through. If you're at the store and you're trying to figure out how much this coat's going to cost because it's now reduced 20%, doesn't mean you can't figure it out, but you might be a little slower to process it than you would have been 10 years ago. Or when information is coming in, when you're sitting listening to a lecture like this, or if you're in a conversation and people are talking too quickly, you might miss some of that information where you wouldn't have when you were younger because you're just a little slower to keep up. So why is it important to evaluate these thinking skills, these cognitive functions, and get a diagnosis? Well, if you're worried that it's more than just normal aging, you've talked with your friends and everybody says they have senior moments, but you're feeling like yours are a little worse than your friends, or other people are commenting to you about some difficulties that you're having, then they're concerned about them. It's important to be evaluated because if there is a problem, we can identify that problem, which means that we can then identify some treatment options. We can give you an idea of what your prognosis is. Is this something that's going to get worse or something that's not going to get worse? Is this something that's going to rapidly progress or not? Later on down the road, we can offer information about competency and functional capacity. So by that I mean, can you still make important decisions? That's the competency issue. Usually that's much later in the disorder, but it's important for you and your family to know if it gets to that point where you're going to need some assistance in making decisions. You're going to need family members to maybe take over management of your finances or your healthcare decisions. Functional capacity, if and when it becomes not safe for you to drive anymore, or should you not be left alone for hours at a time because there's a risk that you'll turn on the stove and then forget to turn it off again. That's what we mean when we talk about functional capacity. Or it could be something much more subtle, like you're thinking about retiring. Is this a good time to retire because you're starting to show some cognitive difficulties? Things like that might be helpful with respect to some lifestyle changes or decisions you need to make. So how do we differentiate? How do we make this distinction between what's normal and what's not normal? Well, there are several different disciplines involved here. Neurology is a big one. Neurologists are the brain experts. They're the doctors who specialize in brain function. So the first thing you want to do usually is get a neurologist and go for a full neurological exam. They'll meet with you in their office, they'll run you through some tests, they know what normal neurological function looks like, and they can differentiate normal from abnormal. If there are some signs of abnormal neurological function, they might send you out for additional testing. And some of those additional tests include brain imaging. So they might send you out for an MRI or a CT scan. What they're interested in there is they want to see the structure of your brain. So they will look at brain volume. Like I said before, there's a normal amount of shrinkage as we age. They want to see if it is normal or not. We can actually look at specific brain regions and see if they're shrinking at a more rapid rate than they should be. So we've gotten very advanced in our imaging techniques. Then they might also send you out for labs, blood work. They want to see if you have hypothyroidism or diabetes or any other medical condition that could explain your cognitive issues. If you're saying you're not remembering things as well, or you feel less attentive or slower, there are lots of medical conditions that could be contributing there, many of which can be picked up on your regular lab work. They're also going to look at your vitamin levels. So you've probably heard in the news about vitamin D and vitamin B. Both of those are important for brain function and memory. So if you have a low vitamin D or B level, they can put you on supplements and get that right back up to normal again. Some doctors will also send you out for an EEG. That is a measurement of the electrical activity in your brain, originally designed to detect seizures, but we're also using EEGs to detect other abnormalities in brain function. So that's something neurologists can refer you out for just to make sure everything's right with respect to the electrical functioning of the brain. And then, of course, the neuropsychological evaluation. Now, a lot of people aren't familiar with what neuropsychology does, so I want to tell you about our field and how we can help in this process. So neuropsychology is specifically the study of how the brain affects behavior. That's one of the textbook definitions. Or how brain damage affects cognitive functioning or thinking abilities. And also how behavior affects the brain. So how psychological conditions like depression, anxiety can affect your cognitive functioning. So neuropsychologists study psychology first. We get our graduate degrees, doctoral degrees in psychology, and then we're required to do a 2-year postdoctoral fellowship in neuropsychology. So that's where we really get into the study of the brain and cognitive functions. So here's another way of looking at what neuropsychology is interested in. On the right side of your slide, you'll see the cognitive functions: language, memory, attention, executive functioning, visual spatial functioning. Visual spatial just means your ability to perceive visual information, and executive functioning is referring to the higher level thinking skills like reasoning, judgment, planning, problem solving. So we're very interested in cognitive functions. And then on the left side of your screen, we're also interested in personality, mood, behavior, quality of life, and how each of these things interacts with the other. So like I said before, we know that depression and anxiety, mood disturbance can affect cognitive functioning. We know that when you're not sleeping well, when you're tired, your attention isn't going to be as good. Your processing speed will be reduced. And then we know that people with attention problems can have anxiety. So they all interrelate, and as neuropsychologists, we're interested in knowing how in a particular individual these abilities are working together or working against each other. In a typical battery within a neuropsychological evaluation, the examiner will be looking at your memory, your language functions, which means your ability to come up with words, your ability to understand speech, your fluency, how quickly you can come up with words. We're going to look at various executive functions, like I said before, your ability to reason, solve problems, plan, and organize. We'll measure processing speed, how quickly you process information, your ability to focus, your ability to manipulate information in your head or sustain your attention over time, or multitask. We have various measures of those different types of attention. And then we'll also give you some kind of measurement of your psychological functioning. In addition to sitting down and talking with you about your mood, we will also give you some kind of questionnaire that will ask you questions about your mood and your psychological functioning in general. So we have individual little mental tasks that measure these various abilities. So the reason that we need these measures to figure out if there's a problem with these various cognitive functions and to determine if it's just normal aging or if there's something more going on is because these functions are hard to understand sometimes in your daily life. They're a little more complex. So a lot of people will complain that their memory is not what it used to be. They feel very forgetful. But it's our job as neuropsychologists to figure out, is it really a true memory deficit where there's no ability to hold on to information? Or is it a problem with the learning, which can be very easily affected by attention? If your attention is not good, if you're not focused, you have trouble encoding the information, you have trouble getting it in. And then of course you're not going to remember it later, and you might think, well, I just can't remember anything. But the truth is that you're having trouble getting it in, which is a very different process than a true memory loss like in Alzheimer's disease. So it's our job as neuropsychologists to tease these different components apart, because that's going to make a big difference with respect to diagnosis and then, of course, treatment and recommendations. So the 3 stages, I've already touched a little bit on the encoding. So the first thing you have to do in order to be able to remember something is to get it into the brain first. So we test this in our office by giving people a list of words or a short story or some designs that they need to look at, and we give them multiple exposures to the information. So we'll read this list of words to you several times, or we'll read the story to you again, and we're looking at the learning curve. So initially you might just remember a few of those words or a few details of the story, but then we read it again, you get a few more details, and again we're looking at that learning slope. You should be learning a little more each time the information is presented to you. Then we go away, we do other things with you for a few minutes, and then we come back and we say, tell me as many of the words as you can remember from that list that I read to you, or from that story, or those designs that you saw. And you're required to just generate as much of the information as you can. That's called retrieval. You are trying to pull up the information that you had learned a few minutes before. Now, a lot of people will have trouble getting the information up. Like I said before, it gets harder as we get older to pull information out. So we then give you a measure of recognition memory, where we just give you a word from the list or a statement from the story or about the story, and you just have to say yes or no. So we say, was horse on that list that I read to you? And you just say yes or no. Was mountain on that list? Was the person in the story wearing a green jacket? Yes or no. So you just have to recognize the information, and that's much easier to do than to pull up the information. So this particular task allows us to differentiate between a retrieval problem, where you got the information in but you just can't pull it up at the time, versus you never got the information in. And that's what consolidation is too, being able to get the information in and then store it somewhere. And the recognition memory test allows us to figure out if you were able to store it. And that's really what memory is. Memory is the ability to store the information, not just for a few minutes while you're thinking about it, but to put it into a long-term storage. So if a person can recognize the information, we know that they actually stored it somewhere. Because if you can't store it, then you're not going to recognize it. And that's how we can tell the difference, and I'll show you later in more detail, the difference between something like Alzheimer's, where there is a true memory problem. There is no ability to consolidate the information anymore, versus somebody who's consolidating just fine, but they're having trouble pulling it up. Or they're having trouble getting it in, and then of course having trouble pulling it up. So the typical neuropsychological battery is administered by a neuropsychologist or a technician who's been hired by the neuropsychologist and trained to administer these particular measures. The data is always interpreted by the neuropsychologist, though. The battery usually lasts 2 to 3 hours. It sounds like a lot of time, but it goes by pretty quickly. The measures are very short and quick. You're engaged one-on-one with the examiner. It's very interactive. It's not like sitting in school and taking a test for hours. It's actually just brief, 5-minute little mental exercises that you're doing that are tapping into all these various functions. So it goes by quicker than you think. And then we look at multiple items of graded difficulty. That means that we might start out with some simple tasks or simple items that then get progressively more difficult, and we're kind of seeing where do you drop out. It's almost like a cardiac stress test, where you get on the treadmill and you start walking, and the cardiologist is just measuring these functions and then kind of seeing, when do you get too out of breath, when does your heart rate get too high and you need to stop. So we kind of push a little bit, see how, we want to see how far you can go with the task as the items get more difficult. We know that you're going to drop out. Nobody's going to do perfectly on everything, but we're just looking to see if, relative to other people of your age, how are you doing? Are you within the normal range for somebody your age? Or is it, are you somehow below the curve, below what's considered normal for your age? So neuropsychology differs from what neurologists can do or psychiatrists can do in measuring cognition, because we offer that objective measurement. So these tasks that we're giving you are measures that were designed by neuropsychologists They've been well standardized and validated, so we know that they're measuring what they're supposed to be measuring. They've been given to thousands of people. We know what the so-called normal, healthy population, how they're doing on these tests. We've separated those people by age so that when we give you the same test, we compare you to other people of your age. So we know already that people who are younger tend to be a little quicker, tend to be able to focus better in certain ways, and then we are going to then compare the 25-year-olds to the 25-year-olds and the 65-year-olds to the 65-year-olds, because we don't want to interpret the normal slowing as something abnormal by not taking into account the effects of normal aging. So we will immediately take that into account. I have a lot of patients who come into my office and they tell me that, you know, their children are worried about their cognitive functioning, but she doesn't understand why they're so worried because, you know, she's 85 years old. Of course she's going to have some difficulties, and I agree with her. Absolutely, you're going to have a little more trouble with your cognitive functions at 85, but it is my job to try to figure out if you're having more trouble than you should be as an 85-year-old. So, so we offer that information in addition to the information that's gathered from an interview, from the person's own impressions of their cognitive functioning, their loved ones' impressions of their cognitive functioning, and then observations that we make of functioning in daily life. There are lots of things that can affect cognitive functioning. So even if you think you have problems that are worse than your friends, you feel like it's more than just aging, it doesn't mean dementia. So the title of the presentation today is it normal aging or dementia? But there are lots of things in between normal aging and dementia. It could be normal aging plus you're not sleeping well and you're tired during the day. We know that fatigue affects cognitive functions. You're less attentive when you're tired. You're slower to process when you're tired. When you're slower and less attentive, it's harder to learn new information. Then you feel like you have a memory problem because you're not learning the information as well. So fatigue, sleep problems can have a huge effect on your cognitive efficiency, how you feel, how sharp and quick you feel. Pain, if you're in pain, if you have a migraine, if you have joint pain, back pain, that's distracting. So it can keep you from being able to focus on what you're trying to focus on, and then of course that has effects on everything else. If you're depressed, if you're anxious, if you're drinking too much, if you have other medical conditions like I mentioned before, if you're on certain medications that can cause sedation. If you're taking a medication that makes you sleepy, then again you're not going to be as focused or as quick. Motivation and malingering, these are less likely to interfere with the test results when we see you, because we just don't see that as often. Most people who come to see us are very motivated to do well, but occasionally we do have to take into account the possibility that somebody does not want to do well because they want to get disability benefits, and so they're going to exaggerate their symptoms, or they've been in a car accident and they're suing and they're not going to try their best. So we do take that into account. Obviously that could affect the results of the testing, but that's not typical. So I want to talk about the pattern of neuropsychological performance, and this is really important as we go through the various disorders that we might be ruling out when a person comes in and says that they're having more trouble with their cognitive functions, they're having memory problems, or they're having trouble focusing. In neuropsychology, we give you all these little tests, and then we look at the data as a whole, and we try to see if there are certain patterns in the data that point us in a particular direction in terms of a diagnosis. Because, of course, we want to find out what it is so that we can then identify the treatment and give you more information about what you can expect. So what I'm going to do over the next few minutes is talk about the various potential diagnoses and what the pattern is that we tend to see in the neuropsychological data, meaning in your cognitive functioning. So mild cognitive impairment is something you may or may not have heard already. It's a fairly new diagnosis, and it came out of the study of people who were complaining of memory problems but didn't show up as being positive for Alzheimer's disease or dementia. So for a long time, these people were called the worried well. But then we started to realize that maybe they were worried for a reason. They were having problems with memory, but everything else seemed to be okay. And if you have problems with memory but everything else is okay, you do not meet criteria for a diagnosis of dementia. For dementia, you have to have a memory problem plus some other cognitive deficit. It doesn't matter which deficit, but you have to have at least one other area that is in the impaired range. So if it's memory is impaired plus your attention is bad, or memory plus your speed of thinking. But if you just have a memory problem and no other deficits in your thinking, as measured, you probably have mild cognitive impairment, and that's the first type, amnestic type. So we've studied this over the years, and we've found that a certain percentage of these people with this particular diagnosis do eventually go on and develop dementia. So we believe that what we found is we've caught these people early in the process before they meet criteria for dementia, but we've caught them now where they're having some memory problems. Everything else is okay, but there is an increased risk they will develop dementia in the future. So we're going to watch these people very closely. We're going to potentially intervene with some medications that can help with memory and maybe slow the progression, and I can talk more specifically about that. So that's why it's important. It's another reason that treatment or intervention is important at this stage, because we can identify with the neuropsych testing that there is in fact a problem here. It's not dementia, but let's get on board and get some treatment and start monitoring closely. And then there's another type of MCI that's called multiple domain or non-amnestic MCI. And this is a little harder to define. The criteria for it are not as well defined. It means that you're having deficits in certain cognitive domains that are not meeting the criteria of dementia, but it's not explained by normal aging either, and we can't find a reason for it. We can't say it's because you have hypothyroidism or because your B12 is low or because you're not sleeping. We don't know why you're having these deficits, so it's become a little bit of a grab bag diagnosis just to say, hey, we know something's going on here. We're not quite sure what it is, but again, we're going to watch and see what happens over time. Alzheimer's disease. This is everybody's biggest fear, I think, and rightfully so. Alzheimer's disease is the most common of the dementia diagnoses, and as we know, it's devastating. And so we want to catch this early because there are some treatment interventions, and it's really important that the patient, and even more so, I think, maybe the family, the loved ones, be educated about what to expect and how to get the support that you need through this process. So Alzheimer's disease, when we're looking at the neuropsychological data, we're looking at the pattern of performance again, and we're seeing certain things that are pretty typical of Alzheimer's. So orientation tends to be impaired. Now that means that they don't often know what the day is. And I don't mean, being off by a couple days because you're retired and you don't remember whether it's Monday or Wednesday. I'm talking about really being disoriented. You don't remember what year it is anymore. You don't even know what season it is. Truly disoriented. You don't know what city you're in. You might not even know what state you're in. And we don't have to go through all of these in detail, but the idea here is that there is a certain pattern. Orientation tends to be impaired. Attention is usually pretty good. People with Alzheimer's early in the disease can stay focused. The problem is that they have trouble learning and then storing the information. That's the real hallmark of the disease, of course. There are some effects on language. You'll notice if you know people with Alzheimer's that they often have tremendous word-finding difficulties, and this can show up pretty early on in the disorder for some people, where it's more than just that tip of the tongue. They really cannot come up with the word, and it starts to influence the fluency of their speech. So they're constantly pausing to try to come up with the word, and then literally a couple sentences later they're pausing again and again and again. So it can become very disfluent type of speech. Executive functioning, sometimes people with Alzheimer's will have trouble solving problems, their reasoning is impaired, their judgment starts to go downhill. They don't interpret visual information as well. Speed usually stays intact in the beginning. They can usually process information as quickly. Of course, all of these functions go down over time with Alzheimer's. It is a progressive condition. But in the beginning, you can differentiate Alzheimer's from other disorders by looking at some of the things that stay intact. In terms of psychological functioning, that's wildly variable. Some people in the early stages can become very depressed because they recognize what's happening. Other people do not have any awareness that it's happening, and so they're not depressed. It's the family members that tend to be more depressed and upset because they're noticing the changes. In terms of imaging and EEG, I mentioned before that our imaging techniques have become quite advanced. Particularly with Alzheimer's disease, we're looking at the volume of the hippocampus, which is a structure on both sides of our brain that is very key in storing memory. And we're finding that in patients with Alzheimer's disease, even very early in the disease, and maybe even pre-disease, before you meet criteria, the size of the hippocampus is proportionally smaller than the rest of the brain. So as I said before, the brain does shrink with normal aging, but with Alzheimer's, what we're finding is the hippocampus is shrinking faster, and it's abnormally smaller relative to other people of your age. And then, so we can see that on imaging, and that's something that can lend support for a diagnosis of Alzheimer's. There is no one test that can definitively diagnose Alzheimer's disease, and this is what's really frustrating for a lot of people. All we can say is that it's probable Alzheimer's when we rule out anything else that could explain the memory impairment and the cognitive problems. The cognitive problems look like Alzheimer's. Like I said, the pattern is consistent with Alzheimer's. The doctors have ruled out anything else that could explain it, and then we can get, you know, these supplementary tests like the brain imaging that shows a smaller hippocampus. There might be genetic testing that shows you're predisposed, but again, that's not going to tell you for sure that you have it. The only way to definitively diagnose, and you've probably heard this before, is after death, when they can take a piece of the brain and look at it under a microscope. But nobody's going to take a piece of your brain out when you're still living, so there's no way to definitively diagnose. But there are ways to get pretty close and be able to say, yes, this is probable Alzheimer's versus something else. There's another type of dementia called diffuse Lewy body disease, which became more well known after Alzheimer's. For a long time, we think that people were being diagnosed with Alzheimer's when they actually had diffuse Lewy body disease because they are similar in their presentation. They're both progressive conditions. They do get worse over time. But in the early stages, there are some differences that can help us differentiate between these two types. The Lewy body in general, the cognitive functions tend to be more variable. Now, people with Alzheimer's can have good days and bad days too, but with Lewy body you see this even more, that there's a lot more fluctuations in function. Also, they tend to have visual hallucinations sometimes, which are pretty rare. Obviously, you don't see that in normal functioning, but in other disorders, it's not very common to have visual hallucinations. These people will often see either people or animals, and they don't seem to be particularly bothered by these hallucinations. I've had patients tell me, yeah, I just wake up in the night and I see this girl standing at the end of my bed, or I'll ask my wife who's sitting in the corner over there. They don't seem to be particularly concerned, but it's obvious to other people around them that these are not real perceptions. So that's common with Lewy body. And then there can also be some gait abnormalities where balance problems and falls, where you don't tend to see that as much with Alzheimer's. So that can help us differentiate. Parkinson's disease is not a dementia diagnosis, but a certain percentage of people with Parkinson's can develop a dementia. Not everybody with Parkinson's will have a dementia. A lot of people with Parkinson's will have some cognitive difficulties, however. They can be slower to process information. They can have trouble focusing sometimes. They can have trouble with their ability to shift attention back and forth. But there is a Parkinson's disease dementia that can happen in a certain percentage, and we need to be able to identify that and separate those people from the people with the Parkinson's alone, because those people are going to need some additional treatment. So we can look at the pattern of performance and see if we're seeing some true memory impairment here. And in that case, we're going to diagnose the associated with Parkinson's and get them on some treatment. Vascular dementia. This is when people have multiple strokes, and you might have known people like this. They can become very forgetful. So it is a dementia, it is a memory impairment, but it's not due to the same pathology that causes Alzheimer's or diffuse Lewy body. Each one of these has a very different reason for the memory problem. With a vascular dementia, it's because there have been strokes that have caused damage to certain parts of the brain, and so you're going to see a very different presentation with people like this. The presentation is going to be very dependent on where the strokes were. So if you have a stroke in the part of your brain that controls language, you're going to have trouble with language. You're going to have trouble either understanding it or expressing yourself in speech. If you have a stroke in another area, you're going to have trouble with different functions. So it's very lesion dependent. The other thing that's different about a vascular dementia is that it has more of a stepwise progression. So if you're functioning at one level and you have a stroke, your functioning goes down. You may have some deficits in certain areas, but then your brain starts to recover, and you do not get worse unless you have another stroke. Then you have another stroke, functioning goes down again, next step down. You recover a little bit, maybe you're not coming back to where you were before, but there is some recovery, and you should not be getting worse unless there's additional insult to the brain. Now that's not the case with Alzheimer's or diffuse Lewy body, where there is just a slow, gradual progression over time. One of the other types of dementia is the frontal lobe dementia. And we call it the frontal lobe dementia because it does affect the frontal lobe of the brain, the part of the brain right behind our foreheads here, where we're going to see very different symptoms in people with frontal lobe dementias, because the frontal lobe is responsible for our behavior. Our frontal lobes inhibit behavior that's not appropriate, and they also initiate behavior that is appropriate. So sometimes you'll see people who become very apathetic. They don't feel like doing anything. They're perfectly content to sit on the couch all day, and I'm not talking about your average couch potato type person, but this is truly abnormal. They will not even get up to go to the bathroom at times. There's just no initiation of behavior. They don't seem to care about anything. Or you'll have somebody who's acting inappropriately. Somebody who never used to curse is now cursing. Or they're making inappropriate comments to people at church. You know, they start to actually have a more childlike presentation. Their behavior is a little more like a toddler who doesn't seem to understand what's socially appropriate anymore. These people do not have memory problems initially. Initially, the memory is actually okay, but these behavior changes and personality changes are so evident that it often helps in diagnosing the frontal lobe. Eventually, the memory will go downhill, and they will start to look more like an Alzheimer's type dementia, but in the beginning, we can differentiate because they present very differently. The only other thing that I wanted to talk about that doctors will want to find out if you're having some problems with your memory or other cognitive functions, you're not focusing as well, processing as well, they need to rule out something called normal pressure hydrocephalus. This is a condition that is very treatable and can cause some cognitive difficulties. So just like in the case of diabetes or a low thyroid or a low B12 level, this is something that they want to make sure that you don't have before they assume that you have something like Alzheimer's. Normal pressure hydrocephalus is a condition in which the ventricles in the brain, so the brain is composed of brain tissue, but there are also spaces in the brain, and the normal pressure hydrocephalus is when there's too much pressure in those spaces. So when there's too much pressure in those spaces, it's pressing on the brain tissue, which then of course has effects on brain function and cognitive functions. The reason wet, wobbly, and weird is listed here is that's kind of the way med students remember the symptoms of this disorder. Wet meaning incontinence, wobbly meaning balance problems, and weird meaning the cognitive difficulties. So those are the three symptoms of normal pressure hydrocephalus. The way doctors will sometimes investigate this further, they obviously see a picture of the brain and see that the ventricles are larger than they should be, and then they can do a spinal tap, take out some of the fluid from the spinal column and then see if you function better when that pressure is released. So you can have a neuropsychological evaluation right before that drain and then right after that drain and see if there's a difference, and that can help identify whether it's NPH. And the reason it's important to identify this, as I said before, is because it is very treatable. They can go in there and put a shunt in that drains that fluid out of the ventricle so that you can get right back to the way you were before. If you don't have a coexisting dementia, because obviously some people with dementia can also have NPH, but at least we can treat the NPH part of it. So that looks very different than other disorders. So how do we minimize our risk of cognitive decline? We know that we're going to go downhill a little bit as we age, just as part of the normal aging process, but how do we minimize that effect? We have studied this for years. There have been some fantastic, well-controlled studies of people, and there are three main things, in addition to some of the others I'm going to talk about, but the three main things that we found consistently in the literature are staying cognitively active as you age, staying socially active, and staying physically active. So the cognitive piece, if you're working full-time, most likely you're getting the cognitive stimulation you need. When you retire, you need to find a way to keep yourself cognitively stimulated. So if that's doing crossword puzzles or, playing brain games on your computer or taking a course online or going to the local community college, whatever it is, something that keeps you engaged and interested, or you're in a Bible study class or a book reading club or something, just make sure that you're doing something in your life that's interesting to you and keeps you cognitively active. Also, if you can maintain your social network or increase your social network if it started to die down, because social activity, in the research we're finding that it limits or reduces your risk of depression. When people start to withdraw from their friends, they can go into a state of depression, or when they get depressed they tend to withdraw socially. So it's important to get that social activity back up again. And social activity also stimulates you cognitively, because just being engaged in conversation works your brain. You have to remember what the person was just saying and remember what you wanted to say next, and it keeps that attention, processing, all of those cognitive skills active as well. And then the physical activity is something that people weren't aware of as much before, but we're finding that when you take a group of people who are at risk for Alzheimer's and you compare them and you divide them in half, and some of them exercise regularly and some do not, we're finding that the people who exercise regularly there's a lower rate of dementia in that group. So eat right, exercise, minimize your stress if you can, get enough sleep, stay mentally and socially active, avoid substance abuse. These are common sense things. These are things that make it worse, so you want to try to avoid these things. How do you compensate if you're having cognitive difficulties? Well, if it's memory, you want to start writing things down. Repeatedly review information that you're trying to learn. Say it to yourself over and over, or write it down and then look at it a few times. Use the crutches, use the electronic reminders, the alarms, the pill boxes, whatever you need to make you function more efficiently in your daily life, reduce the frustration and any potential dangers associated with forgetting. So use those crutches. They're not going to hurt you in any way. If it's an attention issue, try to focus on one thing at a time. Don't try to multitask as much, or minimize the multitasking if you can. Take brief breaks as you need to. You don't want to push and push and push and get tired, and then you can't function as well. Allow yourself enough time for tasks. If you know you're starting to notice you're a little slower, give yourself the extra time, or ask people to slow down when they're talking to you. So much of the information today is coming at us so fast. The television, the iPads, the phones, the movies even, everybody's talking faster these days. So if you need to, and if you can, interrupt and say, could you please just say that again, or could you just give me a chance to write something down while you say that, or could you write that down for me and send it to me in an email? Be creative. So in conclusion, I want everybody to go away from this presentation realizing that a certain amount of cognitive decline is a normal consequence of aging. it's important to recognize and identify the abnormal cognitive decline, and that cognitive testing or neuropsychological evaluation can play an important role in that, and figuring out, is it normal or not, and then if it's not normal, what is it? That gives us important information about prognosis and treatment. It can also give us important information about function in daily life, helping the patients and the families figure out what should we be doing at this point. Do we need to get a caregiver in, or does somebody need to stay with my mom, or what should we be planning for the future? And then I didn't mention this before, but cognitive testing can also help patients get disability benefits or special services or accommodations. If you're still trying to work, there are accommodations that can be put forth in the workplace that can help you stay at work, or if you can no longer work, maybe getting some disability benefits. I've also put at the end here, just for your information, some resources that can be very helpful if you do find that you or someone you love is having some cognitive difficulties. These are particular to dementia, of course. It doesn't have to be Alzheimer's to contact the Alzheimer's Association. They can be very helpful with other types of memory problems as well, but these are some of the local ones and national resources that are available to you. So thank you again, everyone. I'm going to turn it over to questions at this point.
Okay, here we go. So I'll just try that question quickly again, just in case we were not recording, and my apologies. Do you think that hormones and stress might affect a woman more than a man as they age?
Yeah, so what I had said was that hormones can definitely play a role with respect to thinking abilities, and that there have been some really good studies that have shown that women during menopause or perimenopausal women will have more trouble remembering information during that time. It's not a true memory deficit like Alzheimer's, and it is temporary. The studies have shown that the memory function should go back to normal after menopause, and that it does not increase your risk of dementia or other abnormal cognitive decline in any way, but during that period of time there have been documented cognitive difficulties. In terms of the stress, I'm not sure that women are more vulnerable to stress than men are, but maybe during that period of time they have more trouble coping with stress, so that can play maybe a more prominent role with women than men at that particular time of life.
Thank you. The next question, are HMOs like Kaiser generally willing to perform these tests at the request of a patient?
Yes, thankfully. Neuropsychology has made a lot of headway with the insurance companies, and I'm actually a preferred provider with Kaiser, with Blue Cross Blue Shield, with Medicare, with Aetna. We can work with people who have out-of-network benefits, even if we're not on the panels. But yes, absolutely. Usually with a referral from a physician, you can get the neuropsychology covered. It's treated as a diagnostic, so the same as if you were going to get an MRI. At a deductible, you would have to pay out of pocket if you hadn't met that deductible yet. But then the insurance kicks in, and it does cover neuropsychological testing.
Okay, thank you. And what is the latest thought on how much sleep is considered healthy? What about interrupted sleep? That is, you sleep 8 to 9 hours, but it's interrupted.
Right. Very good question. I don't know that there's an optimal amount of sleep that we could say applies to everybody, because there are people who will swear that 6 hours is plenty for them and they feel terrible if they get more than 6, and then other people who say they can't function on less than 8. So there are definitely some individual differences there. What's most important with respect to sleep is how well rested you feel when you wake up and what is your energy like during the day. So if you feel well rested in the morning and you have decent energy through the day, then you don't need to worry. If your sleep is interrupted at night but you're still feeling fine, usually nothing to worry about. The problem is if you're not feeling rested after you've had your normal amount of sleep and you're feeling tired during the day, then I really strongly recommend going to see your physician, getting a sleep study done where you're actually in a lab and they're going to monitor your electrical activity and your breathing during sleep to find out if there's a problem with what they call your sleep architecture. Are you not going through the stages of sleep the way you should? Are you not breathing? Are you not getting enough oxygen? These things will definitely increase your risk of cognitive problems and decline. Sleep apnea is huge these days. A lot of people with sleep apnea, it actually, in addition to making you tired during the day, can increase your risk of stroke. So it's not just about feeling tired. A lot of people don't want to treat sleep apnea. They'd rather just deal with the fatigue. But I just really don't recommend that because it's actually increasing your risk of stroke is what we're finding, and cognitive decline.
Thank you. Okay, how can I get a cognitive test for my parent?
So the best way, I think, is to go to your parent's physician. If your parent doesn't have a neurologist yet, if the primary care doctor feels comfortable referring to a neuropsychologist, that's absolutely fine. Hopefully there is one in your area. If the primary care doc would rather refer to a neurologist first, sometimes they'd like the neurologist to see the patient first, then they can refer over for a neuropsychological evaluation. I'm not sure if you meant just the logistics of doing it or if your parent is resistant to coming in and having a testing done, which we see a lot. If that's the case, then it just takes a lot of kind of talking with your mom or your dad and saying, you know, we're really concerned about your safety here. We want to make sure you're doing okay, and there's some great treatments out there, and if we don't identify this, we can't treat. And so sometimes that'll be enough to get the person to come in, or if you want to contact the neuropsychologist and have them talk with your mom or your dad, that can be really helpful at alleviating some of the anxiety that goes along with this idea of being tested.
Okay. And we have another question. My mom suffered dehydration and was hospitalized and sent to rehab and hasn't been the same. She was 91 and a half, still balancing her checkbook. She will soon turn 93, and it is obvious she is not bouncing back. What tests would you recommend at this time? Even a year ago, the neurologist did not do a battery of tests. Would you even recommend CAT scans or EEG? We have only been to a neurologist, not neuropsychologist.
Okay, so obviously a bunch of different issues here. So as we get older, we do have more trouble bouncing back from things like dehydration. You know, when you're 25 and you have an episode of dehydration, you can bounce back and have no lasting effects whatsoever. As we age, it gets harder and harder to bounce back. Even a simple urinary tract infection can put us under the weather for months. You know, so at 90, 91, having an episode of dehydration and then feeling like your mom just hasn't come back is not surprising. But there's also some factors here. Maybe there is a dementia. Maybe the kind of physical trauma of the dehydration then triggered a dementing condition. So I would really recommend a neuropsychological evaluation. I've seen many people in their early 90s, and we can determine whether the functioning is normal for an early, you know, woman in her early 90s or not, and then talk to the neurologist about whether brain imaging would be helpful. I would say, well, usually they'll do it all at once. They'll send out for brain imaging and EEG and everything, and neuropsych at the same time, but you could talk to them, and maybe that's too much at once, maybe just picking a couple of things and doing it in stages. But I definitely think that it's very valuable information regardless of age.
Thank you. Also, should a person, not necessarily my mom, the one we were just talking about, utilize both a neurologist and a neuropsychologist if they have concerns about memory?
Yeah, so we do slightly different things and we work well together. The neurologist will be involved in coordinating all of these multiple tests and making sense of that information as a whole. So integrating all of this various information and deciding what is the diagnosis, what is the course of treatment, and then following the patient over time for treatment. The neuropsychologist is more of a diagnostician who comes in as a specialty and consults with the neurologist and the family to help with that overall picture. So neuropsychologists are not usually involved in ongoing treatment. We step in, do the neuropsych evaluation, provide that information and our recommendations for treatment, but then we don't continue to see the patient until, unless the patient is referred back again for a reassessment.
Okay, thank you. And this will be our final question because we're bumping up against 1 o'clock. Okay, I have two, so we'll make. Do you have a list of providers that accept Medicare in the neuropsychology field?
Well, most neuropsychologists do accept Medicare because Medicare is actually really good about covering neuropsychological evaluations. So obviously my practice, the Neuropsychology Associates of Fairfax, we have 6 neuropsychologists in that office and all of them accept Medicare. And then there are other individual neuropsychologists practicing who I also believe accept Medicare. And the nice thing about Medicare is they will cover most of it, and then most people also have a secondary insurance that will pick up the rest. So most people with Medicare plus a secondary won't pay a dime out of pocket for neuropsychological testing.
Wow. Okay. What is happening when people ask the same question over and over again? Do they really not remember or just see you and think they need to ask that question again?
Well, that depends. And this is a good question and a good example of how do we know if this is just they're just not focused, they just, they were thinking about other things and they forgot that they already asked you that question. It also depends on within how many minutes are they asking you that same question. If it's, if it's the next day and they ask you that same question, maybe that's, not so abnormal. If we're talking within 5 minutes, they're asking you again, what are we doing this weekend, or what's on the calendar for this evening, or when is so-and-so coming over, and repeatedly asking that is not normal. I can almost assuredly tell you that something's going on with the memory at that point if somebody is repeatedly asking the same question within minutes or even within an hour to ask the same question over and over again with no recognition that they've already asked the question is not normal. So that's where I would suggest going in and getting the neurological evaluation and getting some neuropsychological testing done.
Okay. Well, we will wrap it up with that. And once again, thank you so much to Dr. Sullivan. I've already received lots of comments that say thank you. Thank you. This was very reassuring, put my mind at ease. And so I know that people appreciate your being here, and we certainly appreciate you being part of our seminar series.
Well, thank you so much. It was truly my pleasure.
Great. Thank you. And to all attendees, we have one more webinar left in the series. It's next week at noon, 5 questions to ask about paying for long-term care. So we hope to see you there. And thanks again, Dr. Sullivan. Okay.
Thank you.
Bye.